Birmingham Children's Hospital and also in Queen Elizabeth Hospital. We are not just burn center, we also burns unit for the West Midlands, and we are also burn facility, as you just heard a few minutes ago, for Birmingham and also for Coventry, Nuneaton, all of the rest of the West Midlands. Stoke is actually a burn facility. We know Coventry is burn nothing, but in Stoke it is a burn facility. Sarah, please, can you share yours? I cannot really share from my side.
Just trying to download it now.
Thank you. So if we talk about massive burns on the pathways, what really special about burns? Burns, as I will explain, is one of the severest burn injury any human being can sustain. I'm talking about massive burns. And the first few hours of burn care and management is crucial to the survival of these patients and also the outcome if they survive. And that's why actually the pre-hospital care and ED care for these particular patients, which is very rare, it's extremely important. On average, we receive our patients between 4 and 6 hours to when they arrive to ED in Queen Elizabeth Hospital or Birmingham Children's Hospital. But fortunately, in massive burns, if they are major burns within half an hour, as you saw the pathway a few minutes ago, within half an hour from Queen Elizabeth Hospital, the ambulance service can actually pick and go directly to Queen Elizabeth Hospital or Birmingham Children's Hospital, which we really are very privileged in the Midlands that we have this pathway, because we are linked to the major trauma pathway. So that's really a great plus, because we know the more we have our patients, the quicker we have our patients, the better the outcome. Sarah, did you get my message?
Not yet, it's still downloading at the moment.
Right. So basically, what we worry about when a patient is basically in pre-hospital transfer or is stuck in ED, the two things we worry about. The first thing is hypothermia, because these patients are really, with the massive burns, they lose a lot of body temperature very, very quickly. And we know that if the patient is reach the final destination with a temperature of 34, 35 degrees Celsius, the outcome will be very poor. So warming the patients pre-hospital is vital and very crucial. The second point is the initiation and starting the fluid resource. There is a very strong evidence that is early establishment of fluid resource in these vulnerable patients improve survival. And one of the most critical factor in determining who's going to live and who's going to die, basically the early establishment of fluid resuscitation. And this is very important in children, because in Galveston in the States, they looked at a group of patients who died over a period of 10 years, and that was about quite significant series of cases. And the most important single factor in determining who will survive, who will die, is actually the fluid management in the first 4 hours, which is unfortunately here in UK in the Midlands, is basically it is pre-hospital care, either ambulance services or ED services. So once we have the patient in ED, what we will do is the trauma sequence is declared and the patient will be assessed for trauma, quite right, and the primary and the secondary survey is done, and also CT a CT scan is done straight away, and if there's any problem with airway, there will be also endoscopy done straight in ED. So these are things really we benefited from the trauma pathway that we linked with. We are privileged here in the Midlands that we try to follow and sync with the trauma pathway as much as we can. Excellent. Excellent. Can we go backward, please? Thanks, Sarah. Really appreciate it. Yeah, next slide. So it's a little bit of a model, but basically that shows that the metabolic rate in acute burns is really very high, and it almost 100% more response than in normal. There is 100% increase in the metabolic rate in these patients, and this really carries on for about a year. So it's a very severe injury. Next, please. And there was a very phenomenal paper that was published back in 2012, and this is a landmark paper here in the 2011. One major trauma, I'm sure you are aware of it in major trauma. So for major trauma and major burns, immediately after burns, there is a genome changes, which can change up to 30% of the genome of the body immediately after major trauma or major burns. And this paper from the GLUE grant in the States really has changed everything we do in burn care and has improved a lot of our understanding how all these major changes happens. Next slide, please. And this is really one of our success stories. This is a little girl, 60%, was burned, sustained a flame burn. She was sitting in front of a fire and her clothing caught fire in an early winter morning. And she went to Wolverhampton, New Cross ED, and the primary care, the assessment and establishing the resuscitation was done. And you can see here that her chest was very tight. And by extreme chance, one of the burn surgeons was actually doing a combined case with the orthopods in New Cross at that time. So she went down to ED and did sclerotomies of over the chest, so she could ventilate because she wasn't ventilating at all. Saying that, probably this is the only indication for sclerotomies outside burn center or burns unit. The reason for that is sclerotomies has to be done. You have to take a patient to theaters sometimes. I understand it can be done in ED, but this is not the best environment. And the literature tells us that at least 40% of these sclerotomies are incomplete and has to be repeated again once the patient reach the final destination. The only exception to that is tight chest and unable to ventilate. So that's what we recommend sclerotomies only in if they are in the ED and you intubate the patient and they cannot ventilate. So this little girl came with us and survived her injury. Thanks, Sarah. Move on. And this is just to show you how is the body response to burns, and to some extent apply to major trauma as well. A lot of organs like the liver and skeletal muscles really are extremely active, and that's why in burn patients, almost all of them get hepatomegaly because of the massive transfer of a lot of the gluconeogenesis is activated, and there is a lot of transfer for fatty acids and from the muscle down to the liver, and most of our patients have fatty liver actually after the injury. And you can see here's the metabolic rate also, in the oxygen requirement increases in these organs, but mostly in the liver and the skeletal muscle. Thank you, Sarah. So what's our objective? Our objective is to achieve early wound closure because this will dampen the metabolic response. And also we have to early mobilize. So physiotherapy as important as surgery, and from day one really is very, very important to maintain the passive range of movement if the patient is intubated and ventilated. But as soon as we can wean off the ventilation as early as possible, the sedation, sorry, as early as possible, we start mobilize the patient in edge setting, even with a tube in or the tracheostomy in. That's very important to not to lose the lean body mass. It's very important not to do that, because if in burns, if the lean body mass is reduced by 30%, the outcome, including mortality, increases, and the outcome is really reduced. Metabolic modulation will come through that, how we can modulate the immune response by various drugs that we give, and we'll discuss this in some more detail. Immune modulation, still think for the future, and hopefully what we learned from the GLUE grant and the genomic storm, the same in trauma, that we can modulate this immune response and have really better outcome. Thanks, sir. So what we need to do really, we can click all, please. There's a bit of sequence, 4 clicks, please. So what we need to do here for the surgical early management is to just divide it into the first 24 hours and then the second 24 hours. So in the ED, we do the trauma assessment. As I mentioned, we have to avoid hypothermia. Then we start fluid resuscitation according to the Parkland formula, 4 mL per kilo per percent, and that's given over a period of 24 hours. And also, swift transfer is important. A big line is or as the EMSB says, 2 big lines, and then just transfer the patient. It's very important not to waste time trying to put central lines, because it will be done more aseptically in a clean environment, and as I will explain later on. So once we receive the patient in ED in Queen Elizabeth, we do the same things, and then we transfer the patient straight to theater. And again, our protocol that once we have a trauma alert for a burn, everything stops. Even in burn theater, we stop, and the patient will be ready to take the patient straight to the burns theater. And in theater, the anesthetist will be with us, and we'll make sure that we fix the tube for him or her. And bronchoscopy really should be done early, just to diagnose if there is inhalation injury or not. And then assessment of the depth of the burn, the size of the burn, and then verify whatever has happened in the ED, as the total body surface area, or ED, by cleaning all the wounds, because suit can really be misleading. And it's not uncommon to see a variation of resus and the variation of, total body surface area by maybe 20%, 30%, plus or minus. And also always remember to look at the back of the patient. I've seen it times and times again that a junior doctor becomes overwhelmed with a major burn, and they just forget to turn the patient to see the back, if the back is burned or not. And that's really 18% of total body surface area that could be missed. Once the assessment is done, if there is any sclerotomies need to be done, will be done straight away. And then a few things has to be done in theater while the patient is asleep. A feeding tube and the bowel management system, so the tube from on the top end and the tube in the bottom end, and the central line always is applied in theater before we start these things. And then once everything is clean, we make the surgical plan. We always will go through the early excision and early cover, but the surgical plan is done on admission. That's why a consultant burn surgeon must be in theater with this patient on admission at that time. It's very crucial, really. Planning is one of the key points for success. So what happens after that? The patient goes to the ITU if it's a massive burn, intubated, and they will be stabilized and resus continued and optimized, and make things ready for the second day when total burn excision we'll try to achieve. In real life, we excise as much as we can and we cover with a temporary biological dressing, most probably allograft or cadaver skin. And the two important things we have to really be careful during this period, during this major surgery, is avoid blood loss. We infiltrate huge amount of adrenal solution subcutaneously to prevent bleeding, and we can actually excise burn up to 20% with minimal blood loss. And also for the donor side bleeds a lot if we don't infiltrate with adrenaline. And the second thing that we have to be worried about is hypothermia. Once the temperature goes below 36, invariably the anesthetist will tell us to stop. And also if there is a major blood loss, 5-6 units of blood, invariably the anesthetist will stop us. So we have to be careful with blood loss and hypothermia. Thanks, sir. So that's the E-tube wiring done by the surgeon. They usually do it to the maxillary first premolar. If there's no teeth, we put a screw and then wire it to the screw. It's very important to fix the tube properly, otherwise the airway can be lost. And these things must be done on admission in the ITU or in theater if the patient is in theater. Thank you. And thanks. And then next one, that's the bronchoscopy done. Thanks, sir. And then we clean the wound and move on, Sarah. And clean the wound and assess the depth of the burn, the extent of the burn. Here in the facial burn is covered with appropriate dressing. Exposure is not good for the patients. It's not good for fluid loss and not good for wound healing. And here you can see full thickness burns, the same patient, full thickness burns, the upper trunk, and move on, Sarah. And the arms. Then you assess, do we need sclerotomies? And that's third degree, probably fourth degree to the dorsum of the hand. You can see here the fingers start to claw. So that's a third or fourth degree burn of the left hand. And this is the back, and the scrotum is done. You can see here the depth of the burn, and the scrotum really has to be done adequately till tissues gape open, as you saw in the little girl at the beginning as well. Next, please. You can argue here that the scrotum is in the left leg is inadequate, and that's because it doesn't go into normal unburned skin in distal and also proximal. So that's really very important. If you're doing a sclerotomies, must be done adequately. Thanks. And the bowel management system, the tubing is inserted. Before this is protocol maybe for the last 18 years, to be honest, here in Birmingham. And since then, we used to have invariably everybody get constipated, and invariably we get ALIAS after that. And the mortality from that is quite high. So the bowel management, trying to keep the bowel open all the time, is very, very important. And really avoid distension and the ALIAS and the compartment syndrome. Thanks. So what's the ongoing care? The ongoing care is, as I said, after the wound closure, is avoid sepsis. Sepsis is the killer #1 for burns. Usually happens at day 6 in acute burns, and you have to be very vigilant for diagnosis. That's why we don't give prophylactic antibiotics at all. We only give patients antibiotics if there's a procedure, any surgical intervention, or if we are if there is a massive dressing as well, or any other procedure that the patient will have, we will have prophylactic antibiotic, but not routinely, not on admission. And the reason for that is we don't really want to develop multi-resistant organisms, which is very, very common, because burns, they will become septic. So we need to preserve our heavy guns for later on, which usually at the 2nd week. Environmental temperature is very important, and I'll show you why in a minute. And active mobilization and modulate the hypermetabolism is really important as well. Thanks, Sarah. You can see here in a graph, this is the paper that everybody really quotes about the environmental temperature and the importance of the ambient temperature to be around 30 degrees centigrade. And you can see here the difference in the metabolic rate when the temperature is lower, and it really increased the metabolic rate by significant amount of percentage. I mean, here it goes 50% over if the ambient temperature is lower, because the patient try to exert more energy and consume more energy to keep the body temperature up, and that's really can be exhausting metabolically to our patients. Thanks, sir. So that's why we do the next click, please, and the last one as well. So that's why we do the metabolic modulation. And the commonest and the cheapest is beta blockers, propranolol. Why we use propranolol? Because it's non-specific, so it'll just reduce the heart rate and also reduce the catabolism in the periphery, in the muscle. So actually, it's very useful for our patient, and has one of the very, very few class 1 evidence that we have in burns care that use of propranolol and non-specific beta blockers improves wound healing, can improve length of stay, and in children actually can improve survival. Thanks. Next slide, please. So the principle is to achieve wound closure is to do early excision, and the early excision really will reduce all these metabolic requirements for this massively injured patients, and that can be achieved by early surgery. And because we are fighting against time with wound healing and also against time against sepsis, everything counts, and really the window of margins, there's a small narrow margins of error. If we really not careful, for example, not to look after the patient, the wounds becomes colonized and not clean. Any hitches in the critical care or the surgical management of these patients can really affect the survival, because these patients are very vulnerable. Any complications can actually tip the balance to non-survival from survival. That's why we really need to work from plans and protocol, and there's good evidence in the literature that units that works from SOPs, the outcome is invariably better than units that doesn't follow SOPs or protocol. And the target really for the surgical management and to achieve near complete wound closure or minimize the wounds by the end of 4 weeks. If this is not achieved, the patient invariably don't survive. Thanks, please. Can you shift, Sarah? Oh, sorry. That's fine. So the advantage of early excision is basically survival is increased, metabolic response is reduced, the wound infection reduced, and also sepsis and hospital stay. But the problem with early excision in non-experienced hands or in the centers that are not used to these protocols is that it can cause actually the patient can blood loss can be tremendous, and the patient can get hypothermic, and then the outcome becomes compromised. But we don't do it in two situations. If the indeterminate depth of the burn, like mixed depth burn, we have to wait and see. We don't go early. We excise early only the full thickness burns that 100% we show is full thickness burns. Anything we think is deep dermal or less deep, we just wait and see. And also in elderly patients, we don't really jump in the guns and do this very early. We have to know our patients. We'll wait maybe for 48 hours, maximize the patients, get the anesthetist to see the patients, and everything will be set to do one surgical procedure, trying to finish everything in one setting for these elderly patients, because you can't really take them back again to theater. So you need to optimize them before you take them to theater. Thank you, sir. So The timing of early excision is very important, and we know from the hemodynamics of these patients and the positive physiology of these patients, as you see in the top row, the first 3 days is the surge is flourishing, the resuscitation is happening, and then between the second and the third day there is a fluid shift, and sepsis, as I said, happens at the beginning of the second week. So where we do the excision, either early or immediate or early or late, it really is, you can see from here that the more you do it earlier on, immediately in between day 0 and day 2, probably is the best outcome before fluid shift happens at the second day, because you give these patients loads of amount of fluids, and then all of a sudden these fluids shift from extravascular to intravascular space. Usually this happens by day 2, and if you add on the surgical intervention, and which is huge, and these patients, they end up with ARDS and the pulmonary edema, and then they really compromise their outcome. Obviously, if you wait till the next week with the wound colonized, graft take will be poor, and the patient actually can go septic after surgery. Thanks, sir. And there is good evidence that early excision improves mortality in a meta-analysis that is done back in 2006, but there isn't any randomized trial done since then. So this data, as it stands, is still the golden standard. Thanks, sir. Does it move, sir? Thank you. And the only problem is the blood loss. Obviously, the blood loss is more in cases of early excision. Thanks. Next one. Thanks. It doesn't move, sir. I think we're having trouble with the
Naeem, the presentations are moving, but I think there's a little bit of a time lag.
Okay.
We keep losing you. So we're on the blood loss presentation.
Okay. I will take my my camera off, will be better. So the blood, yeah, after the blood loss, thanks. I mean, that's how we prevent blood loss. We do infiltrate. You can see here shaving a burn with no blood loss at all. And this is really important for us to avoid any to compromise the circulation. Next, thanks. And also the length of hospital stay is improved. Thanks. Next one, thanks. Yeah, sorry, the slides are a little bit heavy.
Yeah, so we know on the pictures of patient lying on his front.
Yeah, I will move on. Keep moving. I think we are in the end, towards the end anyway. Yeah, this is yeah, move on, please. Yeah, plasma resuscitation. As in trauma, plasma is even more controversial in burns rather than in trauma. And as you guys have very good evidence now that the earlier you give plasma, probably the outcome is better. In burns, we're lagging behind you, and we really need to learn from you and your literature that is really coming along, that giving plasma can actually have impact on survival. Next, please. And you can see here in this cohort of patients in the publication a couple of years ago that giving plasma to patients earlier on in the pre-hospital setting actually improves survival. Thank you. In burns, still the evidence not very strong, and there is a lot of resistance actually to give acute burns plasma during the resuscitation period. However, saying that, there is some, especially in Southeast Asia and China, part of the routine care of early management of fluids and resuscitation of burn patients is to give plasma a couple of units every day till the wounds is halved. And actually their outcome is tremendous. Thanks. I'm sorry about the jumping up and down the slides, but I'm sure we can have some discussion. Thanks.
Thank you very much. It actually wasn't too bad at all with your connection issues. Thank you. A wonderful talk. And